make some videos for us. I hope it was interesting. Then we have come to our last speaker before the break. I can assure you that it's really worth it to pay close attention because we had some really, really good classes from last year. So it's Professor Dr. Gorik Ooms. He's a human rights lawyer, policy advisor with Herwin, a network of social and circular economy and enterprises in Belgium, and visiting professor global health at Ghent University. During the first half of his professional career, he worked with Médecins Sans Frontières. From 2004 until 2008, he was the executive director of MSF Belgium Operational Center, and after that, he became an academic and was professor global health law and governance with the London School of Hygiene and Tropical Medicine. And then he returned to civil society work on a just social and environmental transition with Herwin. Thank you for coming all the way over here. We're
Hey, I'm here. Thanks for inviting me. And thanks to my wife for bringing me here, for taking me here. I have to admit that I was a bit reluctant to take on this topic. What do we mean with bottom-up approaches in global health? I mean, where is the bottom and where is the up? If the bottom is the people whose ability to lead healthy lives is most jeopardized by structural violence, resource constraints, etc. And if the up is the meeting rooms in Geneva and New York where decisions are taken, then you don't want a 56-year-old white, male, straight Christian professor of global health to lecture you on that, right? I have a huge credibility deficiency that some were talking about, that my friend Saya was talking about. And yet I'm here. And I was willing to tackle this topic because one of the reasons why I left global health professionally, I mean, I'm still a global health professor, but no longer paid as one. I'm working with civil society, is linked to the subject, is linked to the bottom-up thinking and to my thinking about responsibilities. In the last 3 years as an academic at the London School, I got more and more interested in climate change and the impact of climate change. And then I thought, isn't this crazy that universities in high-income countries are thinking about how to tell people in other parts of the world to cope with climate change? Shouldn't we stop climate change first? Isn't that our first responsibility as high-income countries? And so I joined a group of small enterprises who are really trying to apply. I don't know if you're familiar with the donut economy, that concept, in reality, and to see how can we change within our society, bottom up, and stop our responsibility or end our responsibility for climate change. So you could say I'm not really an expert in bottom up, but I'm a big fan. And so I thought to take you through my CV in a way and to explain how I got where I am now and the contradictions I met and the mind shifts and the eye openers, etc. But to help with that, no, that's the wrong one. Yeah. I wanted to use this slide from someone who has probably more credibility on the topic than I have, Professor Madhukar Pai. And I think it explains rather nicely in a couple of lines the difference between global health and development as the global north sees it and how the global south wants it. And so charity, philanthropy versus human rights. Big difference in view. Aid donations versus equity and social justice. I think that explains itself. Donations, development assistance versus reparations for harm done. Really important. Different mindset, very different mindset. Saviorism, the white savior. I've been guilty of that. MSF is perhaps an expression of that. Versus autonomy and respect. Dependency versus self-determination and self-sustenance. And if you look at this, I think the bottom-up thinking and the importance of bottom-up thinking comes out very clearly. But yes, at the same time, there is a bit of tension. I wouldn't say contradiction between the elements in blue there. Human rights, equity, and social justice, for me, demand international transfers as well. Sharing of resources, mutual support, not only between people in the same country, but also at the global level. But in the absence, and that was in the introduction of today, in the absence of a global governance mechanism that can organize it, those transfers are inspired by charity and by donations, and they come with a lot of power, and they have an impact on self-determination. Now, logically, it doesn't have to be like that. This is really due to the governance structures or the absence thereof. You can see I'm hurt, I'm wounded, I had surgery. It was, I don't know how much it really cost to society. I didn't pay anything so far. Social Security paid for it. I think there will still be a bill coming from the hospital, but most of it will be coming. Did I receive aid? Was I a beneficiary of aid from all you Belgian taxpayers in the room? In a way, yes. We don't call it aid. And when I pay my taxes at the end of the month, I don't call it donations. It would be crazy to call it donations because I don't have a choice. I pay my dues and I use my entitlements. And that can happen at the national level. At the global level, we don't have mechanisms for that. And that's why transfers between countries have developed a very different nature. And that's a problem. So going back to my CV, I've worked about 20 years, a little bit less, for MSF. And why did I join MSF? When I was 10 years old, I lived in Burundi. My father was a development worker there, and he hated it. And he thought the project was hypocritical and it was intended to make Belgium look good and not really help the people of Burundi. And so I grew up with that idea, okay, development assistance, there is a huge problem with it. But at the same time, I was interested. That year in Burundi really shaped had a very strong impression. So I studied it and I read about it in the newspapers, etc. And my conclusion at that time, 23 years old, was, well, I don't want anything to do with development assistance as such, but humanitarian assistance in times of crisis. Let's make an exception for that. Let people in other parts of the world work out their own issues, but, and I'm saying it's very naive, my thinking has developed since then, but humanitarian assistance, when there's a crisis, yes, then we have an obligation to move in. And in my head, it was rather consistent. I was also a board member of a small NGO called Songe, Soutien aux ONG de l'Est et du Sud, that was already practicing or trying to practice the bottom-up approach and support local organizations, local NGOs. Well, 15 years later or 20 years later, MSF is bigger than it was then. Songe no longer exists because they couldn't get funding for that kind of stuff. And that's important not to forget. We can be idealistic, but charity over there is still hugely important. It's a problem that throwing it out comes with some risks. 2000, we went to Mozambique. I was head of mission there. The word head of mission, I think it's problematic in itself, the word, I'll come back to that. And we had these huge floods. I don't know if anyone here is old enough to remember that. And it was crazy because the floods were completely predictable. We knew they were coming. We knew they were coming. We were so sure that 3 days before the floods hit the town of Shokwe, we created a new team there, a new basis. And the Ministry of Health of Mozambique was crying, asking for help, for trucks, for small boats to evacuate people. And the so-called donors didn't want to pay for that because they said, oh, Mozambique, it's time you take care of your own problems. That's not sustainable if we pay this for you, etc. Then the floods hit in the night from Saturday to Sunday. On Sunday morning, the US Embassy stood on our doorstep with a check of $100,000 that we could spend on helicopters to evacuate people, which was far more expensive. But suddenly we had moved from development to humanitarian crisis, and now everything was possible. In the weeks after, we realized that a lot of the children and people we rescued were HIV positive and needed antiretroviral treatment. $10,000 per person per year at that time. That was before generics were allowed. And all those same agencies said, no way, we're not going to do that in Mozambique because that's not sustainable. And even people in the Ministry of Health said, we don't want it. We knew that cheaper versions, generics, were coming at $365 per person per year. The budget of the Ministry of Health was $5 per person per year. And so people in the Ministry of Health said, we don't want that kind of dependency. We want to take care of our own problems our own way, and it will not include antiretroviral medicines. So if you want to apply bottom-up strictly in this situation, it would have meant let the HIV positive people die, because there was no solution within the means, within the resources of Mozambique. So yes, I'm all in favor of bottom-up, but let's be careful of the consequences and think about that. For me, it also challenged this whole notion of what is development? What is a humanitarian crisis? I mean, what is HIV? It was killing more people than during the Civil War, but at the same time, you couldn't say it was just a one-off temporary crisis. And one of the responses to the HIV crisis was PEPFAR in the US, the President's Emergency Plan for AIDS Relief. So really this emergency approach, which didn't make sense. And I clearly remember someone of the Ministry of Health telling me, you know, for us, MSF is the after-sales service of the IMF and the World Bank. The IMF and the World Bank came in the 80s and the 90s and destroyed our health systems, which is why we now need MSF. And that's something I will not easily forget. And so it really changed my mind. Another answer to AIDS was the Global Fund to fight AIDS, TB, and malaria, which also I got involved in, not as a board member, but on one of the constituencies. And it also, I mean, it was a good solution for the situation at that time, but it raised questions. Why only 3 diseases? Why AIDS, TB, and malaria? Why do we now have antiretroviral treatment in Mozambique in the most remote area and still no emergency obstetric care? Civil society had a big influence, civil society from the north, but also from the south, in the Global Fund, but only part of civil society. So if you think of bottom-up thinking, yes, this will result in harmony and everyone will ask for the same. No. People living with HIV/AIDS have other demands, have other needs, and they will use that agency. And perhaps the biggest dilemma in trying to figure out a better way was a question of assistance to governance or assistance to civil society, which the Global Fund struggled with a lot. And there were some good reasons for that. If you have a country that criminalizes homosexuality or sex work, that makes it rather difficult to tackle HIV/AIDS. But on the other hand, I mean, the Belgians in the room, can you imagine that the European Commission would come to the government of Belgium and say, well, we've noticed there's a bit of a corruption issue in Belgium, and your governance stinks a bit with all these different layers, and they cannot get their act together. So from now on, we will use the ESF funding only for civil society in Belgium. Belgium would be furious, and rightfully so. But yet, in the Global Fund, that became a way of doing things. In some countries to say, okay, we'll support governments, and in other countries, we will support civil society. Okay, then I became, as mentioned already, director of MSF Belgium, and one of the biggest things in the first months was the tsunami. And I think MSF was the first organization to tell people, please stop giving us money. Because there's no way we can spend all this money wisely on this crisis. And it was a very hard message. But in the tsunami, people were either dead in the first wave or they were surviving. And it was much more about development and future thinking than about a humanitarian crisis. Again, that made me realize how important this charity thinking is, because people were really upset. And we had all the good arguments and we had all the right answers why we were doing this. But yeah, if you go into charity, you have to take into consideration what works and what not. Another thing that upset me greatly in that position was what our Department of Communication called donor porn. You know what donor porn is? It's typically the white nurse with a black baby, because that works. And it's not what MSF is about. And the teams are mixed, etc. But it works. And if you go completely away of that, then you pay a price for that. Now, finally, in that period, and perhaps one of the elements that I'm most proud of, MSF is, in a way, if I dare to say it, a colonial organization. We have missions. MSF has missions, and MSF has sections. And it's not a coincidence that there are 19 sections in high-income countries, and that in low and middle-income countries, we have missions. That whole language, that whole thinking about it is problematic in itself. Yet some of the arguments behind it make sense. The idea that every MSF section has to develop autonomy and self-reliance and not rely on support from the others, I think that makes sense. But the consequence of that is that it's almost impossible in low and middle income countries to raise funding on their own and to find volunteers, etc. Now, the thing I was proud of is that during those years, we managed to create MSF South Africa, MSF Brazil, and MSF India as sections, not missions. So we started changing it. But it's also middle income countries. So if you want to decolonize global health, and I think it's really important, keep in mind that it's very difficult to decolonize part of this reality in a world where the inequality is still what it is and the power balance that comes with it. It's a huge challenge. So then I became an academic, first in Antwerp at the Institute of Tropical Medicine. I went to Yale, Georgetown, and then the London School of Hygiene and Tropical Medicine. And I tried shifting the Global Fund and the thinking about it from AIDS, TB, and malaria to universal health coverage. And universal health coverage, I mean, it means different things to different people, but for me, it's the closest concept to realizing the right to health in a comprehensive way, support to health systems, etc. And to some extent, it worked. If you compare the SDGs with the MDGs, universal health coverage is now there. But what we realized during those years was that actually the priority for most of the donors, and I'm not talking about all the people working in those agencies, but the people who make the decisions at the end, infectious disease control is still more important than health system strengthening. It's not a coincidence that AIDS, TB, and malaria are infectious diseases. And so this notion of common interest, I think, is missing in this scheme. It deserves a place there, and it should be further investigated. I remember René referred to it. It's obvious in infectious disease control, but also in international tax justice. There are also common interests between countries. In climate change, it's obvious. And finding a spot there in our thinking for common interest is important. And if I have time enough, I want to tell you a small story about that. That for me was a real eye-opener. You have these big AIDS conferences every 2 years. And in 2012, for the first time, it was in the US. Before, they always moved around. And the reason was that until 2010, you had to do an HIV test to get a visa for the US. And so lots of the civil society organizations would not be able to attend the meeting because of that. In 2009, that changed, and the US no longer asked for it. And everyone was happy. I mean, everyone within the AIDS advocacy groups. But one of the leaders of PEPFAR at that time told me, we have to be very careful with this, because the only reason why we're not doing that, why our government is not doing this anymore, is because it finally realized that the risk of a new epidemic, of a reinfection from people traveling from Africa and other parts of the world, of the US, makes no sense. This will have an impact on funding. Now that that fear is gone, you will see HIV funding stabilizing. It won't increase anymore. And unfortunately, he was right. Now, during those years, I was fortunate to become friends with Equinet. René Lewenson, who was mentioned, was one of the important people there. And I think we can really learn from Equinet, and specifically on this topic of navigating civil society and governments, ministries of health, etc. So this is from their website. I quickly wanted to show this. They work with professionals, civil society members, policymakers, state officials, and others for the purpose of equity and social justice. And it's really interesting to see how they do it. They work with ministries, but they keep their distance. They work with civil society. And often you have civil society suing the government and at the same time being in those same meeting places. And so if I have 1 minute to make some publicity, another important person in this network is Moses Mulumba, who will defend his thesis in Ghent on the 4th of November in the afternoon, and you're all invited there. So coming to conclusions, and there for me, I mean, this whole story was personal, but take from it what you can use and throw away what you can't use. But for me, the principle of do no harm should come first, not only in medicine, not only in public health, but also in global health. Think about what we're doing. And currently, high-income countries are doing a lot more harm through climate change than whatever they can make up for through a global fund or in other way. We should not let our desire for autonomy and self-reliance lead to poor health for poor people in poor countries. We need international solidarity. We need international transfers of resources as much as we need them at the local level. However, such transfers should be based on reliability, ideally on legal obligations like the right to health, perhaps moral obligations, or perhaps common interests. And I think researching how common interest can move and can perhaps transform global health. For me, that would be a priority. But the conclusion of that is, yes, if you don't want to rely on discretionary funding, if you're aware of the problems that come with it, then bottom-up approaches make huge sense. But we should be aware of our credibility deficit when we talk about that. And I'm afraid that there is no perfect answer to this tension between the focus on states or civil society or specific groups. But that doesn't mean that it's impossible. And I think Equinet shows that it is possible to navigate those difficulties. And I really encourage you to look at their website and at some of the projects that they've been doing, because I think we can all learn a lot from them.